Welcome all. Today we will see about discuss about hyperkalemia. This is important electrolyte abnormality, but not as commonly seen as hypokalemia, but it is more dangerous than hypokalemia and needs emergency treatment. The serum potassium level more than 5.5 milliequivalent per liter is called as hyperkalemia. It occurs in 10% of hospitalized patients. The etiology of hyperkalemia, it can be due to increased intake of potassium in the form of IV fluids containing potassium or high potassium containing foods or potassium containing drugs. It can be due to tissue breakdown in the cases of bleeding into soft tissues, GI tract, body cavities, hemolysis, rhabdomyolysis, catabolic state. It can be due to transcellular shift in the cases of tissue damage, severe exercise, in metabolic acidosis, aldosterone deficiency, during administration of succinylcholine. It can be due to impaired excretion in acute renal failure or chronic renal failure due to use of potassium sparing drugs like ACE inhibitors, heparin, NSAID, cyclosporine, and reduced tubular excretion in Addison's disease, hyporeninemic hypoaldosteronism, and amyloidosis. And one must always look for pseudohyperkalemia, which can be due to traumatic hemolysis due to blood sampling, during blood sampling, and in thrombocytosis and marked leukocytosis. So these are all causes of hyperkalemia. It can be due to it can be pseudohyperkalemia, or it can be due to transcellular shift or inadequate excretion, decreased distal delivery, hyporeninemic hypoaldosteronism, renal resistance to mineralocorticoids, advanced renal insufficiency or primary adrenal insufficiency. Clinical features, it is also called a silent killer because it can lead to fatal cardiac arrhythmias in potassium above 6.5 or 7. Otherwise, presentation might be a vague muscular weakness. Severe hyperkalemia can lead to hyporeflexia and gradual paralysis. It can present like tingling around lips or fingers, slow or irregular pulse or collapse due to dangerous bradyarrhythmias. Now we'll discuss the ECG findings of hyperkalemia. If serum potassium is 6 to 7 milliequivalent per liter, can see tall peak T waves. If it is 7 to 8, we can see the finding as loss of P waves, widening of QRS complex. If it is 8 to 10, their QRS merges with T waves and formation of sine waves and more than 9 milliequivalent. It can lead to even cardiac arrest or ventricular tachycardias. So diagnosis is based on history and laboratory analysis. The urinary potassium excretion rate or transtubular potassium gradient (TTKG) are used to differentiate renal hypoaldosteronism from extrarenal causes of hyperkalemia. This TTKG is calculated by a formula urine potassium into divided by urinary osmolarity divided by plasma osmolarity divided by plasma potassium. And it is used to differentiate renal hypoaldosteronism from extrarenal causes of hyperkalemia. Extrarenal causes due to increased dietary intake. It can be found if there is increased potassium, urine potassium excretion more than 80 milliequivalent per day and TTKG is more than 10. And renal causes can be identified if there is decreased potassium excretion less than 20 milliequivalent per day and TTKG is less than 3. This is the flow chart of approach to hyperkalemia. If it is more than 5.5, we have to rule out pseudo hyperkalemia. If the answer is yes, there is no further action. But if there are potassium is more than 6 or ECG changes, we need to emergency treat the hyperkalemia. If both answers are no, then we have to take history, physical examination, and basic laboratory test. If there is evidence of transleadership, we have to treat accordingly. Or there is evidence of increased potassium load, you have to treat accordingly and reevaluate. If it is no, then you have to assess decreased urinary potassium excretion. If less than 40 millimole per day, you have to order urinary electrolytes. If urinary sodium is less than 25, it is due to decreased distal sodium delivery. Then you have to calculate TTKG. If it is less than 5, it is due to reduced distal potassium excretion. If it is more than 8, it is due to reduced tubular flow. Reduced tubular flow can be due to advanced kidney failure or reduced extracellular volume. And reduced distal potassium excretion. You have to administer 9 alpha fluorocortisone. If the TTKG increases more than 8, it can be due to low aldosterone. Then you have to calculate renin. If renin is low, causes might be diabetes, acute glomerular nephritis, tubulointerstitial disease, PHA type 2, NSAIDs, beta blockers. If it is high, causes may be primary adrenal insufficiency, isolated aldosterone deficiency, heparin, ACE inhibitor, ARV, ketoconazole. TTKG is less than 8, then it is due to tubular resistance. It can be due to drugs, drug induced or other causes of hyperkalemia like tubular interstitial disease, sickle cell disease, renal transplant, or SLE. So treatment, coming on to treatment principle for the treatment of hyperkalemia are antagonism of membrane effects of hyperkalemia by administration of injection calcium gluconate, then potassium movement into the cells by giving insulin and dextrose infusion. Administer 25 to 50 gram of glucose together with 10 to 20 units of regular insulin. Or there we can use injection sodium bicarbonate. It is given IV slowly over 10 to 20 minutes. Or we can use beta 2 agonists like salbutamol nebulized form or parenterally. Dose recommended is 20 milligram in 4 ml of saline by nasal inhalation over 10 minutes or 0.5 mg by IV infusion. Another way of treatment is removal of potassium from the body with the use of loop or thiazide diuretics or cation exchange resins such as sodium polystyrene sulfonate, it is called as Kxalate, which promote the exchange of sodium for potassium in the GI tract. When given orally, the usual dose is 25 to 30 grams mixed with 100 ml 20% sorbitol 3 to 4 times daily. Sorbitol helps in preventing constipation, and the most rapid and effective way of lowering the plasma potassium is hemodialysis or peritoneal dialysis. If all other methods fail, then the last resort for reducing hyperkalemia or refractory hyperkalemia peritoneal or hemodialysis. Thank you.